Question: can hospitals and emergency departments run so smoothly that waiting is eliminated, quality is world-class, and at lower cost? Yes, they can. But the first step is to discover why they don't. I'm Jeff Dreher. I'm an emergency physician and operations expert, and I'm here to show you what I discovered in my search for the answers on how we can improve the system that delivers care. Have you ever waited for care? Well, I've heard many horror stories. What did it feel like waiting in a busy emergency department with a sick child, a loved one, or yourself been sick? Feelings of concern turn to worry and then to disbelief and anger, then despair. Please help us. We need a solution to this problem. Waiting for care causes harm. This is a very unfortunate case of a high school senior rowing champion who had a full ride scholarship to an Ivy League school and a promising future, an Olympic hopeful. One day while rowing, he developed a scratch on the back of his leg, and over the weekend that scratch worsened. He went to the emergency department at Monday at noon and he waited. He waited many hours for care. And that scratch was not just a minor problem. He had necrotizing fasciitis, the flesh-eating bacteria, and the treatment of this is amputation. Multiple amputations. He left the hospital 6 months later with no legs. This should never happen to anyone. This is not a rare occurrence. Things like this happen. This is why we need to fix this problem. So this is our current reality. Patients wait for care, care's delayed, quality suffers. We run our hospitals at a high bed occupancy rate. We have overcrowding, we have diversion, we've got staff burnout, we've got staff shortages, and we have low operating profit margins. So as a frontline clinician, I've been concerned about all of these things, but I never really have even crossed my mind about these operating profit margins because that's outside my control. But to be honest with you, we need to really pay attention to this because it's a huge part of the problem that is all self-perpetuating and involves all of these factors. And for me, this has been a career-long problem, 38 years of this problem. And it's not from a lack of trying. We have tried many methodologies. In the 2000s, we started using Six Sigma, followed by Lean. But these two methodologies, even though they're great at solving process problems and removing waste, they're ineffective against boarding, overcrowding, and diversion. And frankly, there's no sense of urgency to fix this problem. It's been going on for 38 years. I found it very interesting when I noticed there was a causal relationship among all the problems that we have, and we have been trying to solve the wrong problem. We're not getting to the root cause. The problem is we have low hospital operating profit margins, so administrators save money and lower costs. The easiest way to do this is to run hospitals at a high occupancy rate. This causes waiting. It's inherent. I'll show you that connection. And there's delays in care when you wait for care, and quality suffers. The ER in the hospital backs up so much that there's overcrowding, boarding diversion, staff burnout. And this further causes revenue to decrease, which then causes the problem to self-perpetuate. Let's find out how we can save costs. More waiting happens, more quality issues, more burnout, more low margins. That's why this has been going on for 38 years. So the problem all began in 1983 when the government decided to pay hospitals different for care. Prior to 83, it was a fee-for-service and on a cost basis. After 83, DRGs, which are diagnostic-related groups, were actually invented, and they based a payment on this. It was predetermined and fixed and value-based, which they thought would lower the cost of healthcare. What it did was it put a huge wrench in our system and actually lowered the margins. I was shocked when I found this graphic. From 1995 to 2022, the number of hospitals with a negative operating end-of-year profit margin ranged between 33% and 53%. That is hugely low, and rural hospitals suffered the worst. Many hospitals have closed over the years. And this graphic shows what the median hospital operating margin has been in times of stress. It's been running low, 2%, 3.3%, 0.8% during COVID. These margins are low. Margins are extremely important because that's how we innovate. That's how we educate. That's how we reward our staff. That's how we create programs for our community that may not be profitable, but good for the community. And it's good for financial stability. If you have a good operating profit margin, when staff actually empty a position or leave, you can actually fill it immediately. When the margins are low, they just let that position not even get filled for a while. Because the margins are low, what hospital administrators do is they actually get together and they look at this balance sheet. The financial minds, which is the CEO, the CFO, and the rev cycle people get together and they look at the balance sheet. They look at the revenue from hospital operations, which is hard to increase. In fact, it's been going down with all the new rule changes. And so they look at where are our costs. Well, we've got some fixed costs, which are supplies, utilities, insurance, and maintenance. But then we have this large chunk that's actually staffing, 48 to 56%. That's huge. And so what they do is they look at staffing. How can we optimize it? What can we do to alter the staffing to make it actually work better and make our hospital spend less on staffing? So administrators control costs by adjusting the number of beds that are staffed. Not all of the licensed beds of a hospital are open and staffed. They downplay this to keep the occupancy rate above 85%. Below this, they are not profitable. But there is a cost to patient care by keeping the occupancy rate this high. This is the most important slide of the deck. High occupancy rate causes waiting. This graphic on the right is the utilization curve, which is the same thing as occupancy. As utilization of any resource, such as a hospital bed, increases above 80%, the wait time increases exponentially. Like I said, this is the law of gravity. It's set in stone. So running hospitals at over 85% occupancy is causing hospitals and patients to wait for care. And with waiting, you have delayed care and quality suffers. Speed to treatment delivers the highest quality of care. In heart attack, every 30-minute delay increases your mortality by 7.5%. With stroke, same thing. You need to restore tissue, perfusion. And when you do this, you return to your normal life. You go back to work. It also cuts down the cost because remember, we're being paid by DRGs. So if I can treat you rapidly, get you out of the hospital quicker, the cost of the care decreases, your quality of life increases, satisfaction increases, everything's good. With delay in care, different story. Heart attack, delay in care can cause CHF or death. With CHF, you have a lower 5-year survival rate and your quality of life is poorer. With stroke, you can end up paralyzed on one side of your body, not able to walk or talk, and you might end up in an ECF wearing a drool pad and a diaper. Not a good quality of life. And with sepsis, it's even worse because we're already behind the 8 ball with a 30% mortality rate, even with the best care. And so this young gentleman suffered tragic problems with this. And the thing is staff, when you take care of somebody and you know that if the system only ran better, that we could take better care of patients, this is the stress of healthcare. It's not taking care of sick people. That's what we train for. It's actually when bad outcomes occur and we lay awake at night going, what if things would have been different? I can't imagine. And working in a chaotic, overcrowded environment that's harming our patients causes the staff to burn out. That's why we're having staff shortages. As a result of the overcrowding, boarding, diversion, staff burnout, and turnover is causing more financial losses, causing the cost of care to increase, forcing administrators to further cut costs. Thus, the cycle continues and the problem is self-perpetuating. And there's losses when we run a business like this. Patients will walk out and the ambulances are diverted. This accounts for about $9.5 million of net profit loss annually. That is the cream of the crop money. Take in staff turnover, doctors, nurses, and training costs, and actual market share loss. We're talking about $11 million of net profit loss. That's quite a bit. So it's pretty clear why we have this problem. Low margins, which started in '83. cause this whole thing to snowball and perpetuate. So what's the solution? Well, the solution is to look at this as a system. What in the system is causing to have problems? And any solution must look at it as a system. It must be a system solution because you can't just fix one department or one process. It's got to be everyone in the boat rowing together to solve the problems. It's got to make financial sense, otherwise it's not going to go. It's got to fit with the mission statement of the hospital. The goal of the hospital is to take great care of all patients at all times. And the problem is we have flow. So it must promote flow, and the way to do this is by removing the bottlenecks. You can ask any frontline staff, do we have bottlenecks? We have many bottlenecks. What's the biggest one? We need beds and staff. But do we manage our beds and our staff? Do we actually manage those resources? It needs to be leadership driven, and it needs to have rapid results. You know, we've been doing process improvement for many, many years with Lean and Six Sigma. And the results cannot be fast sometimes. I mean, when you do a small project, certainly, but we need rapid results. We need something that's going to happen in 3 to 6 months, and it needs to be easily implemented, and it needs to be simple. So what process improvement methodology actually works to improve systems? Well, TOC does, the theory of constraints. The thing about TOC is it makes it simple to solve problems. It starts with the basics. What is the goal of the system? Well, to take great care of the patients. What's getting in the way of that? It's called the constraint. Everyone knows that we need more staff and more beds. So what it does is improves the efficiency of the constraint. Right now, we have a lot of process improvement people that aren't actually working on improving the efficiency of our beds. And that is the problem. You put measures in place and you put management in place. I'm going to talk more about this in the next presentation. So what are the results you can expect from implementing a project using the theory of constraints? By focusing on the constraint and managing the fact that our beds weren't being utilized, we actually implemented a process where we actually alerted when we started to get backed up and got the whole hospital involved in actually helping us move patients and improve flow. And what this did was it dropped our length of stay of admitted patients in the ED as well as discharged patients in the ED. When you do this dramatic of a drop, what happens is you actually increase your capacity. It's like adding 280 staff bed hours a day. That's like dropping a fully staffed 12-bed ED pod into your ED. By the end of the project, the chaos was much less. We did have bad days, but they were much less frequent. In fact, we were working as a team. What was amazing is that it dropped left without being seen from 40 patients a day to 4 a day. And that increased the hospital revenue by 9%, over $1 million a month in net profit. Quite an amazing solution and quite rapid results. Here it is in a chart form, and it shows the Press-Ganey scores, which went up dramatically. I've never seen a 10-point jump in Press-Ganey scores like this just by improving patient flow through your emergency department and hospital. Quite amazing. Well, I hope you appreciated the talk. If you have any questions, please reach out to me. My name is Jeff Dreher. Here's my contact information. You can email me or text me. I have a lot of content on YouTube. Here's my channel, Jeff Dreher, MD, MBA. I talk more about how to solve problems in healthcare. In my next several presentations, I'll be talking about exactly how you implement TOC. And also, I'm presenting this at the TOC ICO Innovation Summit in Las Vegas in October of this year. You can find out more information at tocico.org.